Hello, I'm Angela Alston, and this is my presentation for Theoretical Foundations of Behavior entitled Utilizing Physical Activity to Address Cardiovascular Disease in African American Women. So an overview of the health problem is that according to the American Heart Association, cardiovascular disease, CVD, is the leading cause of death for African American women. Cardiovascular disease kills nearly 50,000 African American women annually. 49% of African American women over the age of 20 have some type of heart disease, such as clogged arteries in the heart, arms, and legs, stroke, high blood pressure, angina, chest pain, and 1 in every 2 African American women in the United States has heart disease. Only 1 in 5 African American women believe they are personally at risk. Only 52% of African American women are aware of the signs and symptoms of a heart attack, and only 36% of African American women know that heart disease is their greatest health risk. So what are the risk factors for CVD? High blood pressure, high cholesterol, and smoking are key risk factors for heart disease. About half of all people in the United States, that's around 47%, have at least one of these 3 risk factors, but all start earlier among African Americans, according to the Center for Disease Control, the CDC. Several other medical conditions and lifestyle choices can also put people at higher risk for heart disease, including diabetes, having overweight or obesity, eating an unhealthy diet, physical inactivity, drinking too much alcohol. So what are the social determinants for CVD in African American women? Social determinants have been proven to be an important factor in the development of cardiovascular disease and related risk factors. Social determinants of health refer to social conditions in which people are born, grow, work, and live. These social conditions include, but are not limited to, race, ethnicity, geographic location, socioeconomic status, and psychosocial factors. Numerous studies have established inverse association of SES with various CVD risk factors, including hypertension, diabetes, and obesity. In addition, a growing body of research has shown a strong association between psychosocial factors and CVD risk factors. The risk factors are higher among African American women than any other ethnic group. People with fewer socioeconomic resources, less education, lower income, have less healthy diets, may be less physically active, and have poor quality sleep, all of which lead to the early development of heart disease risk factors. This overabundance of adverse social and environmental factors are major contributors to the development of CVD. Approximately 26% of African Americans are living in poverty, compared with 15% in the overall population. The median family income for African American households is $43,151, compared with $66,632 in the U.S. population. Most people experience stress from jobs and major life events, but African Americans have unique sources of stress, which are likely to include persistent economic and health-related stresses, according to the American Heart Association. So why is it important to address this problem in this population? Well, heart disease is the leading killer for all Americans, but in African American women, heart disease develops earlier, and deaths from heart disease is higher than any other ethnic groups. CVD is largely preventable, and prevention programs represent an enormous return on investment by reducing some costs and promoting patient well-being, including the length and quality of life. Despite the known benefits, most U.S. adults do not obtain the recommended amount of physical activity, which is 150 minutes of moderate to vigorous intensity physical activity weekly. Conversely, African American women adults report lower participation in physical activity than other racial ethnic subgroups, as well as African American men. In addition, African American women report higher rates of sedentary behavior than any other racial ethnic subgroups. Consequently, African Americans suffer higher morbidity and mortality from poor health outcomes associated with insufficient levels of physical activity and sedentary behavior. In addition, cardiovascular disease has become our nation's costliest chronic disease. In 2016, CVD cost America $555 billion. Expenses associated with CVD are expected to soar in the coming years and surpass medical cost estimates for other chronic diseases such as diabetes and Alzheimer's disease. By 2035, the cost will skyrocket to $1.1 trillion. So why physical activity? Well, physical activity has been linked to decreased risk factors and deaths related to CVD. Physical inactivity is the fourth leading risk factor for global mortality and the leading risk factor for non-communicable diseases such as cardiovascular disease. Physical activity can reduce the likelihood of morbidity and mortality from a myriad of poor health outcomes, including heart disease, cancer, diabetes, cerebral vascular disease, and obesity. Successful strategies to increase and maintain increases in physical activity among this at-risk population are critical. Physical activity interventions would promote positive change in health behavior, reduce risk for chronic disease, and reduce disparities between the group and the U.S. population overall. African American women are one of the least active demographic groups in the United States and are disproportionately burdened by chronic diseases, which could be reduced by interventions focusing on physical activity. So, previous interventions promoting physical activity in African American women was an internet-enhanced 6-month physical activity intervention applying the social cognitive theory in its evaluation of physical activity in African American female students. Internet-based physical activity interventions have recently shown potential as a high-reach, low-cost method to promote physical activity. The program's primary focus areas in reference to the social cognitive theory were outcome expectations, enjoyment, social support, and self-regulation. The website was grounded in the constructs of social cognitive theory that explains behavior in a reciprocal triadic model. Triadic reciprocal causation is the single most important aspect of the social cognitive theory as applied to health promotion. It is made up of personal factors, behavior, and the environment. The model illustrates how the behavior of an individual can and will be affected by personal factors, environmental elements, and vice versa. So not only can the environment bring change within a participant, but the participant can bring change within the environment. The participants were able to access physical information on the website, physical activity information on the website, interact with other participants, and record physical activity through self-monitoring tools. The participants were rewarded with usage points according to the frequency and duration of their use of the website. In addition to the study website, the participants were encouraged to attend 4 supervised exercise sessions each week. They were also encouraged to walk the track of the University Recreation Center or to attend cardiovascular-based activities such as Zumba or cycling. The exercise sessions were intended to provide a supportive environment to assist them in achieving the physical activity goals that had been set for them. In addition to meeting the knowledge component, self-efficacy was met through the social modeling and persuasion from participating with similar peers. Observational learning was implemented through exercise videos and outcome expectations through blog posts, videos of African American women performing physical activity, and the exercise tracker. Social support was met through the blog discussions, message boards, and exercise sessions. Behavioral capability was also addressed through exercise plans, exercise videos, and blogs. Overall, participants reported a significant increase in physical activity from the baseline to 3 months. However, physical activity subsequently regressed back to the baseline levels at the 6-month assessment. 50% of the sample completed all assessments and reported a significant median improvement in moderate to vigorous physical activity from 82.5 minutes per week at a baseline to 115 minutes per week. So the other intervention is the Heart Healthy and Ethnically Relevant, which is referred to as HER intervention. Also utilized the trans-theoretical model of change and the social cognitive theory. This intervention sought to modify physical activity in African American women to reduce CVD risk. This intervention used community health centers as a setting to conduct this intervention. They conducted a comprehensive standard care intervention plus 12 months of telephone counseling and monthly tailored print materials on increasing moderate to intensity physical activity and diet. The intervention strategies were grounded in the TMC theory, and participants received stage-based behavioral counseling, narcissistic goal setting, a community resource guide of free and low-cost programs and facilities, and ethnically tailored educational materials during their appointments. Participants also received 12 stage-matched and ethnically tailored newsletters, an in-depth introductory telephone call, and up to 14 brief telephone counseling calls from her research staff over a 12-month period. The counseling sessions included an assessment of the participant to determine if they were in a pre-contemplation stage, contemplation stage, preparation, or maintenance stage. Based on what the nursing staff determined from this assessment, the participants were placed into 3 categories: not ready for change, beginning to change, or making changes. If the participant wasn't ready for the change, they were then advised to consider making changes, and if they were beginning to change, they were advised to make additional changes. The healthful habits of the participants who were already making changes were simply reinforced. They were all assisted in setting physical activity and dietary goals. Primary outcomes for the study were minutes per week of moderate to vigorous physical activity and self-reported dietary fat. Physical activity was to be measured by accelerometers, but many of the women did not wear them, and a sizable number of the women did not return them. So as a result of the outcome measurement, it had to be replaced with the Community Health Assessment Physical Activity Survey, CHAMPS. Consistent with the TMC, the intervention hypothesized that changes in physical activity and diet would be mediated by self-efficacy for overcoming barriers, as well as social support and decisional balance. The intervention had a final sample of 266 participants that reported an average of around 3.5 hours per week of moderate to vigorous intensity physical activity on the CHAMPS. This intervention provided an important opportunity to evaluate the effectiveness of culturally appropriate, theory-based, healthcare center-based physical activity and dietary counseling for CVD risk reduction in financially disadvantaged African American women. So based on the evaluation of previous interventions, a proposed intervention would incorporate the trans-theoretical model of change and the social cognitive theory with culturally appropriate strategies. Culturally and ethnically appropriate strategies are critical with this population in regard to increasing their perception of self-efficacy. This process includes 4 methods of learning: performance, outcomes, vicarious experiences, physiological feedback, and verbal persuasion. I mention this because of the importance of African American women seeing images of themselves achieving and maintaining the health behavior is considered a vicarious experience and is very important. African American women are more likely to move from a stage of contemplation to preparation and action if it has been shown that women just like them have been successful in doing so. I would initially use the trans-theoretical model to assess the person's stage of readiness, and based on this result, determine next steps. If they are in the pre-contemplation or contemplation stage, I will provide information on benefits and risk of the health behavior, motivational counseling, and then continue to follow up until they are ready to move to the next stage. If the person is in the preparation or action stage, I would then advise them to make additional changes and encourage enrollment into the program. If they are in the maintenance stage, I would of course reinforce those healthful habits and again encourage them to enroll into the program. The overall program design would be designed and implemented to meet the core components of the social cognitive theory, which are knowledge, perceived, self-efficacy, outcome expectations, goal formation, and social support. In order to meet the knowledge component, the program would provide or should provide stage-based behavioral counseling, ethnically tailored educational materials, and nutrition and physical activity-based weekly didactic sessions. The program would continually work to build the participant's self-efficacy from beginning to end, as it should be threaded throughout the length of the program in different ways, from motivational interviewing to group didactic sessions, follow-up calls, web-based information and interaction, and other forms of social support. Outcome expectations would be developed collaboratively with the patient to identify the goals and objectives that will assist in achieving the desired behavioral change. Goal formation would entail the establishment of specific challenging goals to encourage and evaluate performance, as well as provide feedback and reinforce commitment and acceptance. And social support would be achieved through a small group exercise sessions, blog discussions, message boards, and I would even recommend incentives to invite a friend or family member to join. I would recommend the time of the program to be 1 to 2 years in length, be ongoing with a revolving entry date, as we know the process and the stages of the change model are not linear. There will be occasional relapse before maintenance is achieved. I would also advise against self-reporting, but try to structure the program to collect solid information that could be used to improve and/or develop more effective interventions. In summary, cardiovascular disease-related morbidity and mortality among African American women pose serious challenges to the health of our society. While physical activity and dietary change are critical for reducing CVD risk, health behavior change is difficult. In a systematic review of interventions by Lomax, the report determined that most physical activity interventions for African American women were too short, that's 2 to 6 months, and generally had limited follow-up to prove that changes were long-term and or continued beyond the intervention. I would recommend future interventions are implemented for 1 to 2 years in order to truly assist participants in achieving maintenance of the health behavior. African American women disproportionately suffer from preventable chronic diseases, which could be reduced by implementing physical activity interventions. So in conclusion, continued funding, research, and development is still needed to continue health behavior interventions for African American women in order to reduce their burden of risk for chronic disease, such as cardiovascular disease. The following slide showcases my references. Thank you for your time, and I look forward to seeing some of your presentations as well.